This conference will now be recorded.
Okay, good afternoon, everybody. Is the screen visible to you all? Hello?
Yes, sir. Good afternoon, sir. Yes, sir.
Uh,
It's visible.
see the screen both? You can see
Yes,
the
sir.
screen, right?
Yes, sir.
Okay. Okay, we'll start today with a new part of stomach, and that's ulcer disease. Yesterday we had finished with Helicobacter pylori, and we had talked about the various kinds of gastritis. So now we'll talk about ulcer disease today. And the difference between erosion and ulcer is very important to understand because erosion is much more common. Ulcer comparatively is much less. Now, this is basically an inverted figure in the sense that this is the mucosa of this patient, the epithelial layer, you got the lamina propria, and then you got the muscularis mucosa, right? So this is basically the whole thing is the mucosa, and then you have the submucosa, the muscle layers, and then you got the serosa. Okay, now very difficult to understand. So this green one is what a erosion is. Now, erosion by definition is a superficial breach in continuity. Whether it's also it's erosion, it has to be a breach in continuity of the epithelial cell layer. So there's a breach in continuity both here and here. What is different is, see, this is the muscularis mucosa layer. In a erosion, it never extends beyond this layer. So the limiting part of erosion is that is the superficial part of the mucosa which is eroded. That may only access the lamina propria, it will not breach the muscularis mucosa. That's why erosion is always bigger. That's number one. And number two, remember the size of the defect always less than 0.5 centimeter. That's less than 5 millimeters. In contrast, you can see this figure. This is much larger. It's a larger breach. So it's always more than 0.5 centimeters. It is always breaching beyond the muscularis mucosa and for a variable depth. It can go to the submucosa. It can go up to the muscular layer. It can go up to the serosa and can be the serosa as found in perforated ulcers. So the deeper extent is variable. What is important to understand is the muscularis mucosa is the layer which defines whether you're treating an erosion or a ulceration. Okay, now coming straight away to the peptic ulcer disease. Now, peptic ulcer basically was a very general term for use for all ulcers in the stomach, not only for stomach, for duodenum, and even for esophagus. And this definition implied that there is an acid peptic digestion. Acid peptic digestion basically means a digestion occurring in the presence of acid and pepsin. That's why it is an acid peptic digestion. So this was a general term initially coined, and later on they understood the various parts of the or various types of ulcer. Now, if you look at the classification of peptic ulcer, as you can call it, the peptic ulcer disease, that's why the name disease. Why? It's not a single entity. You have various kinds of ulcers making up the whole peptic ulcer spectrum. So you can have a duodenal ulcer, very easy to understand, not very difficult. Gastric ulcer has been divided by the modified Johnson's classification into 4 types, or rather 5 types. The first one is a pure lesser curvature incisura ulcer. Now, the most common site of gastric ulcer, remember yesterday we said the vertical line and the transverse line where they intersect, because incisura angularis. So it's the most common site for the gastric ulcer. That's type 1 gastric ulcer, the most common. Type 2 is a combined duodenal and a gastric ulcer. See this combined duodenal gastric ulcer? Now what is slightly different is that this may not be a duodenal ulcer, it can even be a prepyloric ulcer. So basically what we are looking at is a dual ulcer. One is very definite, that is a gastric ulcer. The other is slightly variable in the sense it could be a duodenal ulcer, it could be a prepyloric ulcer, because both of them behave similarly. So it is a combination of duodenal ulcer and gastric ulcer. The third one is a prepyloric ulcer, plain, and this or a pyloric ulcer. Because yesterday, remember, we talked about the anatomy. We said from the incisura, you draw a vertical, that is vertical to this, you draw to the greater curvature, and you reach the right segment of the stomach, that is the pylorus of the stomach. And then we said that you got a sulcus intermedius out here. Sulcus intermedius somewhere here. Okay. Now this sulcus intermedius is always 2.5 centimeters proximal to the pyloric sphincter. So if there's a pyloric sphincter, 2.5 centimeters, you got the sulcus. So this is basically the pyloric canal, and this is the pyloric channel. So this whole thing is the pylorus, which is divided into 2 parts. So you can have an ulcer prepyloric. That prepyloric is strictly between the sulcus intermedius and the pyloric sphincter. So that's strict. And beyond that, you would have a pyloric. So pyloric ulcer, prepyloric ulcer, and duodenal ulcer. Okay, that's why prepyloric and pyloric ulcer. Now, just as a remembrance out here, that both of them could be malignant. This malignant, this malignant, this malignant. A dural ulcer by definition is hardly ever, very, very rare to have an dural ulcer turning into malignancy. Then come to the fourth one, and that's a very high gastric ulcer. See the ulcer out here? It's a very high gastric ulcer. And type 5 is basically an ulcer which can be found in any other site. Usually it's medication induced, and this could be any part, could be greater curvature, it could be at a gastrojejunostomy site, so on the jejunal side of the gastrojejunostomy, so this could be anywhere. Okay. Now type 2 and 3, that's why this enclosure, they are associated with hyperacidity. And a question very commonly asked is that if you have both a dural ulcer and a gastric ulcer, what is known as a dual ulcer, which comes first? Now it's very, very clear. It is the dural ulcer which comes first and gastric ulcer comes later. It's not the reverse. Why? Because the gastric ulcer by definition would be a condition which would be found either in a hypochlorhydric or achlorhydric. Now in a hypo or an achlorhydric, you never expect a dural ulcer, right? So the dural ulcer comes first and gastric ulcer comes later. And dural ulcer dialysis is a term which can be, you find in a number of textbooks. Now this term is denoted to mean all ulcers which are behaving like a dural ulcer, meaning thereby all ulcers which have either a normal acidic or a hyperacidic milieu in the stomach, right? That basically means what? That means a dural ulcer. That means a type 2, type 3, and type 5. That is gastric ulcer. NSAID induced ulcer at any other site. So 2, 3, 5 plus dural ulcer, they together make what we now know as a dural ulcer dialysis. So I hope up to this point it is very, very clear. Now, yesterday we did refer to what MAO and PO means. Now, in relation to a peptic ulcer disease, this is basically just what we were talking about yesterday, how to measure it. So I'm not going to go over that again. But one thing you need to remember is that there could be 3 things you can use for a stimulated acid study. Now that stimulation can be derived from number 1, histamine, pentagastrin, or tetragastrin. Among all these 3, the most commonly still being used is the pentagastrin, which is a synthetic polypeptide derivative of gastrin. And the major mechanism of action is through ultimately histamine. How does it do that? It basically ECF cells that in turn stimulate the histamine receptors on the parietal cell. Okay, so it is an indirect stimulation of the histamine producing cell, and that histamine produced and gets attached to by its own receptor to the parietal cell and thus stimulate the production of acid. Now this can be injected either intravenously, intramuscularly, or subcutaneous. All the 3 routes are available, and in 2 forms, either as a bolus or as an infusion. Okay, now the usual form or the usual method of injecting is an intramuscular dose of 6 microgram per kilogram of pentagastrin, and the peak acid output is obtained obtained during a 60-minute period, 10 to 30 minutes following its administration. That means you give the injection right now and then you start following it after 10 minutes. Variable 10 to 30 minutes, right? You start following. You don't expect the high acid output immediately after the injection. Is that clear? So you have to have some waiting time. Only then you start assessing the acid. Now, what happens to the acid in a dural ulcer and gastric ulcer? Very, very clear. It was basically very difficult to understand. Talking about achlorhydria, hypochlorhydria, normal acidic, hyperacidic. So let's be clear about it. A dural ulcer. Number 1, there could be three milieux. Number 1, you got a higher BO and a higher MO. First method, the first type of acid milieu found in dural ulcer. Number 2, a normal BO but raised PO on stimulation, which is perhaps the most common. That basically means what? That basically means that you have a meal, you'll get a more than normal stimulated acid content as compared to a normal person. Now, I'm a normal person. I take a meal, and let's say my peak acid output comes to about 15 milligrams. But the other person who's got an ulcer, dural ulcer, instead of 15, he would be having 30. So what is the difference? The difference is that the peak acid output in a normal physiological condition and in an abnormal dural ulcer condition would be different. The BAO in both the patients would be exactly similar. You understand what I'm trying to tell you? So here what is seen is a normal acid content, the basal, but an abnormally raised PA, right? And the third could be a condition where you have both BAO and PO absolutely normal. So there's no change. There's no change. But one thing is very certain is that you never have a below normal acid content in a dural ulcer patient. Is that clear? Never. So either we have one raised, That means BO raised, or you have PO raised, or you have both raised, or you have both normal. Right? So 3 types of acid contents found in a patient dural ulcer. In addition, what else do you find? You find increased baseline gastrin levels and impaired feedback mechanism. That's explainable, because if there had been a normal feedback, the gastrin would have been suppressed. Gastrin secreted, reached a pH of, let's say, 2 or 3, immediately back impulses say no more gastrin required, and the gastrin subsides, secretion subsides. But there's something wrong with this feedback. Gastrin keeps on being produced. Increased rate of gastric emptying, delivering increased acid load per unit of time into the duodenum. Now, what happens at the pyloric sphincter? It allows the food to mix with the acid, keeps on mixing until it decides that yes, now it can be released to the duodenum with a proper acidic content. Now, here what is happening? Something wrong at the pyloric sphincter. It starts releasing food before it is being completely digested, in essence, draining a lot of acid into the duodenum. So the rate of gastric emptying is very fast, leading to what? Increased acid load per unit of time into the duodenum. Another thing would happen. Normally, when the food reaches the duodenum, immediately what gets secreted? An alkaline content. From where? The pancreatic and biliary. They are both alkaline. So that also helps in neutralizing the acid content of the food which is coming recently from the stomach into the duodenum. They both mix and the acid is knocked off by the alkali. But suppose if something wrong is the buffering capacity of the duodenum buffering capacity, which is trying to buffer the acid release from the stomach, is defective. So what is going to happen? There is going to be increased acid in the first part of the duodenum. Okay, so there's a decreased bicarbonate secretion for some reason or the other. So decreased buffering capacity, rapid emptying time, increased gastrin level, and an altered or a normal acid. Remember, altered or normal is very important. Every dural ulcer does not have an abnormal acid content. Be very sure about that. Don't go with this impression in mind. You could well be having just normal acid content. In contrast, let's see what's having a gastric acid secretion. The 5 types come into play. 2 and 3, we said normal or increased acid content. Why? Because they are part of the dural ulcer diathesis, right? But type 1 and type 4 are pure gastric ulcers. So what is happening here? Either normal or subnormal. Normal or subnormal. So you basically have a spectrum or a pendulum. The pendulum is in the middle, that is normal. You can either have below normal, you can have a higher normal. So the normal both overlap, gastric ulcer, duodenal ulcer. But hyper, only duodenal ulcer, below, only gastric ulcer. Very easy to understand, right? So the middle point is a normal acid. This is hyper, this is below. So in the middle point, it could well be a gastric ulcer, it could well be a duodenal ulcer, but hyper, always duodenal, below, always gastric. Very clear? Right. Now, in addition to that, what else is wrong in a patient gastric ulcer? Primary fault with the mucosal defense mechanism. I'm sorry, I've spelled it's been typed wrong. Correct the spelling. So a weak mucosal defense, right? A weak mucosal defense for some reason or the other. Most commonly, the gastric ulcer found in which patients who are taking a lot of NSAIDs. A very, very glaring example these days. The most common cause of gastric ulcer. Now, what do NSAIDs do? Remember last evening we talked about that, or last afternoon we talked about that. That they are the primary reasons why the whole of the defense mechanism breaks down. Number 3, a duodenal gastric reflex, which components harmful for the gastric mucosa. Now, there's something about the pyloric sphincter. The normal duodenal content is being shoved back into the stomach, containing what? Pancreatic juice, bile, lecithin, all of them damaging to the mucosa. So that's another added feature for a gastric ulcer, which could be responsible. NSAIDs and aspirin, direct damage, and the most important culprits. Right? So the acid content either normal or subnormal. That's why I put it in black color. The weak mucosal defense, the duodenal gastric reflex, and NSAIDs and aspirin. Okay. Now, what is the pathology of a duodenal ulcer diathesis? We just said variable acid secretion, right? Okay. Most commonly found in the first part of the duodenum. A variable exchange on the muscularis mucosa. I already specified that. Now, what do you find in the floor of a duodenal ulcer? You find obliterated arteries, arterial endoarteritis obliterans. And you can find nerve endings also in the floor of the ulcer. What else happens? Now the ulcer tries to heal itself. The body defense mechanism tells you, look, heal yourself. Tries to heal itself. Healing by what? Fibrosis. Where? In the base, that means underneath the floor and around. Okay, so underneath the floor, that's the base, and around fibrosis starts occurring, leading to what? Distortion of that part of the duodenum. And that distortion has been interpreted as a number of terms which simulate normal life things. Like, for example, a clover leaf appearance on barium. Narrowing of the first part of duodenum would cause what? Ultimately, duodenal obstruction, which has been misnomer or misinterpreted or misnamed, I would say, as a gastric outflow obstruction. So everything in the region of the pyloric sphincter, whether it's beyond or it's before the pyloric sphincter, has been named as a gastric outflow obstruction. So here also, if there's a duodenal obstruction, it will be termed loosely as a gastric outflow obstruction. Now, if you have two ulcers, anterior and posterior, it's known as the kissing ulcers, right? Now, the tendency for anterior ulcer, once it starts burrowing deeper and deeper and deeper, is to perforate. While on the other hand, a posterior ulcer, when it keeps burrowing deeper, it will lead to what? Penetration posteriorly into the retroduodenal part, and there the problem arises, that is the gastroduodenal artery is lying in the close vicinity, which it is. If it's eroded, then you have a bleeding in a duodenal ulcer, right? What about the gastric ulcer on the other hand? We just now said the most common cause is NSAID and H. pylori. The rest of the causes play a secondary role. These are the two major causes of a gastric ulcer. Usually in the acid secreting areas up to the boundary of acid and non-acid secretion. And the boundary is where? Boundary is the interstitial. And that's why you find the maximum at the junctional area or the curvature at the interstitial. Even type 4 Johnson explainable. Now you would say that this 4 Johnson, this is not a junctional area. This is not a junctional area. But you have to remember what is happening in this condition is that with gradual destruction of the gastric mucosa, what is happening? The fibrosis, and there's a creeping up of this mucosa. Creeping of this largely mucosa, which does not have any parietal cells. Where are the parietal cells? Here. Are there any parietal cells out here? Enter? No, hardly. So these parietal cells of least acid secretion, they would be ascending up. So it is basically even type 4 is explainable because in this condition, these cells, after the destruction of the normal cells, the cells from the antrum, they start migrating up. So mucosa migrates upwards along the lesser curvature. This is a non-acid secreting mucosa. The antral mucosa non-acid secreting. The mucosa which is there in the fundus and the cardia are acid secreting. So this non-acid secreting mucosa migrates up, and the junctional area is not at a higher level. So now you know why a high up ulcer could still be a gastric ulcer, which is explainable on the normal terms of gastric or acid secretion. Okay. Now it's usually larger than a duodenal ulcer. Chronic ulcers, which could be there, which be on the greater curvature and lesser curvature, can give rise to initially found. These were very common descriptions, formation hourglass stomach or teapot stomach. We hardly ever see these stomachs anymore unless the patient has got a very neglected acid or the way never came to a doctor. You could still see that, but it's very, very rare to find a formation of an hourglass or a teapot stomach. But these are, or they could be presenting if you have a circumferential fibrosis. When you get an hourglass, and if you got a fibrosis only in the region of lesser curvature, then the whole thing creeps up like this, and you have a teapot sign. So that's one a teapot stomach. Lesser curvature ulcer could also go deep down, just like a duodenal ulcer. And where does it burrow into? The left gastric artery. On the other hand, the curvature ulcers, which are less common, if they start burrowing deep, they can burrow into the splenic artery. So you see the three major vessels which could be affected by an ulcer which is burrowing down or penetrating deeper and deeper. The duodenal into the gastroduodenal artery, the gastric on the lesser curvature into the left gastric artery, the gastric on the greater curvature into the splenic artery. Very easy, okay, if you understand here, if you remember anatomy. Now, erosion into the adjacent organs can also occur, and one of the most commonly common organ involved is transverse colon. Okay, so it's not logically it is possible that you can still have a gastrocolic fistula. So burrowing into the transverse colon. Perforation posteriorly not common, but if it occurs into the lesser side. But the most common area of perforation in a gastric ulcer is the pre-pyloric area, which perforates. But then that we are talking about a duodenal ulcer, diaphysis ulcer, which although it is there in the stomach, but it's not strictly in the stomach in the sense it is a pyloric or pre-pyloric. Epidemiologically, there are some differences that if you compare the duodenal with the gastric, it is much more common to have a duodenal ulcer, less common to have a gastric ulcer. And if you look at the male-female ratio, the gastric ulcer is equal, almost equal. In a duodenal, the males are 2 times affected as commonly as female. So that means the males are twice common group of patients. But this difference is gradually decreasing. Now you start finding this ratio to coming down and more females affected and lesser as males affected. Initially, this was the disease of the younger age group or middle age group. But now even that is changing, and you start finding duodenal ulcers migrating from that age group to an older age group. Gastric ulcers were also always diseases of the upper age group. So older age group, gastric ulcers were always there, but now duodenal ulcers also are more commonly found in the older age group. Socioeconomic age groups. Why? Because probably one of the reasons described is that this socioeconomic group, that is the lower socioeconomic group, has the maximum incidence of H. pylori infection. And then, of course, NSAIDs are again common for gastric ulcers. NSAIDs do not play a major role in the formation of a duodenal ulcer, right? But here, what we are standing now is understanding is that H. pylori has got an equal role to play in a duodenal ulcer. Why? Because the association is gradually being found more and more. Acid hypersecretion, more common here, hardly ever here, more common in blood group O patients. That's the duodenal ulcer, right? Now, the common signs and symptoms, we always remember that is an epigastric pain. What is the importance of epigastric pain? It is immediate, very severe, or it could be 1 to 2 hours post-perindial. Now, this was an important distinction which we had been taught, and it is still pertinent to a great extent. And that is that in a gastric ulcer, you find the pain appearing immediately after, and is probably as a result of the physical irritation of the nerves by the bolus of the food. Why? Remember, the ulcer is found where? Lesser curvature. And where is Megan-Strasse formed? Lesser curvature. So that means the food, as soon as it enters the esophagus, it takes a route along the lesser curvature. And if it finds an ulcer there, it's going to irritate the ulcer and the nerve endings there. And that is the reason why you have an immediate pain of gastric ulcer, immediate post-perindial pain. On the other hand, the duodenal ulcer can only get irritated when the pylorus releases some amount of digested food, partially digested food into the duodenum. And that occurs only after 1 to 2 hours. And that is why the post-perindial on 2 hours pain is a pain of duodenal ulcer, immediate pain is a pain of gastric ulcer, right? It is a periodic pain, and periodic in terms of interval of months. It's interval of months. It is not in terms of, say, 2-3 days, subsides, and again 2-3 days. The usual story is the pain occurs for 2 to 3 or 4 or 5 months, the patient is absolutely all right, to reappear again after, let's say, even 6 months. So that is the periodicity, right? And the pain could be continuous burning, it could be intermittent. That is the characteristics of the pain. More or less associated with nausea, vomiting, may or may not be there. Bloating is again a common sign, post-perindial bloating. Weight gain again is different. Weight gain is there a feature of a duodenal ulcer patient, and weight loss is the feature of gastric ulcer. And the reason is easy to understand. We just now said that as soon as the patient has something to eat, the pain appears. So the patient learns not to eat, so that he will not have pain. And a patient of duodenal ulcer will have pain when? 2 hours after having some meal. And he finds out that as soon as he has something, that pain disappears. So he learns to eat more. A gastric ulcer patient learns to eat less. A duodenal ulcer patient learns to eat more. So simple. Duodenal ulcer, weight gain, gastric ulcer, less of it. Bleeding, macroscopic, could be in the form of hematemesis, more of the gastric ulcers. Micro oozing, presenting with iron deficiency anemia, stool with occult blood, and a patient who has a macroscopic bleeding with along with hematemesis, he'll be having malignancy. Okay. Now, malignancy and peptic ulcer, again a very important question to be addressed. And duodenal ulcers are neither pre-malignant or associated with malignancy. You can easily remember that. Never. Okay. What about gastric ulcer? Now, malignant presentations could be in 2 forms. Number 1, a benign ulcer could undergo a malignant change. That means it is a pre-malignant condition. That is possible. But on the other hand, it could be a primary gastric malignancy which is ulcerated and presenting as the gastric ulcer. So a malignant gastric ulcer could be two types. One, a primary ulcer turning into malignancy. Second, a primary malignancy having an ulceration. So there's two types, or there's the two forms of gastric ulcer, malignant gastric ulcer. Okay. Now that is why what has been said, we repeatedly pointing out to you all that when you have a perforation, you find a perforation, gastric perforation, never ever forget to take a biopsy. If possible, excise that part, and that should be underlined in your mind. Never ever do that. At all times, if you have a gastric ulcer, always biopsy it or excise. So always biopsy. If seen as a type of perforation during laparotomy or perforated peritonitis, always excise. Always excise. If it's a small perforation, excise it. Always say large perforation, you will not be able to excise at that point of time. If possible, always do an excisional biopsy. If not, then you just repair it, take a biopsy. If you find such an ulcer on endoscopy, so that is for the open laparotomy or laparoscopy. You find a gastric ulcer, biopsy it or excise it. But if you find the same gastric ulcer while doing an endoscopic examination, then you should take at least multiple biopsies from gastric ulcer, and the minimum is 10 biopsies from a gastric ulcer seen on endoscopy. Other ulcers with possible malignancy, a pyloric gastric ulcer, yes. A pre-pyloric channel ulcer, less common. Okay, so even the pyloric areas, they can undergo malignancy, but a frank and pure duodenal ulcer never undergoes any kind of malignant change. Now, duodenal ulcer diathesis. Now, basically, when you talk about diathesis, we are not only a pure duodenal ulcer, the other ulcers, all are associated with hyperacid states. We have been repeated that. So pre-pyloric, I told you when we are talking about duodenal ulcer, is an ulcer in between the sulcus intermedius and the sphincter. Okay, pre-pyloric. That means just before the sphincter. So that is an area of only 2.5 centimeters length, which would have a pre-pyloric. Anything more proximal to that would be a pyloric, which is distal to the vertical line from the incisura to the greater curvature. So that means in between this line and sulcus intermedius, it would be pyloric ulcer. Between sulcus intermedius and pyloric sphincter, it would be a simple pre-pyloric. Is that clear? It has to be very, very clear in your mind. Between the line from incisura to the greater curvature. After all, that's the whole pylorus part to right of this line. Now that pylorus part to the right of the line is being bisected, or rather, I wouldn't say bisected, divided. It's not an equal bisection, divided into two parts. One between the pyloric sphincter, sulcus intermedius, and the line incisura. So this area, you have pyloric ulcer. This area, you got a pre-pyloric ulcer. Clear? Both can be malignant. Now, combined duodenal or pre-pyloric gastric ulcer, I repeated that to you, just a repetition, that the duodenal ulcer is always primary. This is a question very frequently asked a number of vivas, that which is primary. Duodenal ulcer is primary and gastric ulcer is secondary. Now, stomal ulcers are again belong to duodenal ulcer diathesis family, and these could be seen most commonly in Billroth 2. And Billroth 2, we'll talk about Billroth 2 is all about. You must be knowing what Billroth 2 is all about. This type of specific type of gastrojejunostomy, either Roux-en-Y or loop N. So this is basically, remember one thing, the ulcer is always found on the jejunal side. Why is that? Because the acid content, the jejunal mucosa is not geared up to withstand that amount of acid onslaught. After all, normally, when does the food reach the jejunal mucosa? When it has already been buffered. The duodenum buffers it, the duodenal can buffer it, so that means jejunum gets more or less a normal pH content, neither too acidic nor too alkaline. But here what is happening? The jejunal mucosa is straight away attached to the gastric mucosa in anastomosis. So the high acid content is irritating the jejunal mucosa, breaking it open. So whenever you have a stomal ulcer, remember one thing, the ulcer will always be on the jejunal side, never on the gastric side. Okay? Bariatric ulcer, bariatric surgery and Billroth 2 are the two conditions where you normally find these stomal ulcers. Bariatric surgery, why? Because Roux-en-Y is now considered to be the gold standard, and that is why this is the most common operation done. So you have a lot of stomal ulcers. So how do you diagnose an ulcer? This was basically the basis of a peptic ulcer disease or duodenal ulcer diathesis and gastric ulcer, right? Now, how do you diagnose? One of the best methods is, of course, as you can well imagine, you can think is an OGD examination. You can do a double contrast upper GI You can do a gastric ulcer on OGD, always take a multiple biopsy, already told you. And why you're looking at this biopsy, do two things. Number one, a biopsy of malignancy, and also a biopsy to look for the urease activity to diagnose H. pylori. Yesterday we said the CLO test, right? Campylobacter-like organism, the gold standard. Now, baseline gastrin level may be required when you find a BO and MO2 persist higher than the normal physiological rise, because then you start suspecting a Zolliger syndrome. So again, test for H. pylori and acid study, especially when you're suspecting a Zolliger-Ellison syndrome. So this makes the whole plethora of investigation for diagnosing a peptic ulcer. So what's the treatment? The conservative treatment: abstinence of alcohol and smoking, very, very important. Sleep, rest, and relaxation, which is a very important component. Why? Stress is a major factor, especially in renal ulcers. So a patient who's on constant, persistent stress has to be rested. You have to relax this patient. And that's why part of the prescription, when you write a prescription for a peptic ulcer disease, especially renal ulcer disease, always add on anxiolytics. That is the important part of the prescription. So because we want the patient to rest more, sleep better, and relax, right? Buffer the acid. Always buffer the acid. That's why you write a lot of antacids. The best option is, which is the best buffer for the stomach? Remember, a good meal. It is not the antacids that you take. The basic is a good meal taken regularly, because you don't want a spiking of the acid. I had a meal at 8 o'clock. I should be having the next at 12 o'clock. I don't at 12 o'clock. I was busy with my patient and I decided to take a meal at 4 o'clock. What's happening in the intervening period? The stomach is growling. Growling is what? The acid is there, does not have anything to buffer it. It starts affecting what? The mucosa. So the best option is eat regular and well-designed meals with intervening snacks. Remember, this part is very important. So if you have decided to take your meal, next meal at 4 o'clock in the evening, eat at least a couple of biscuits in between at 12 o'clock or 1 o'clock. We hardly ever do it. We hardly ever do it. But that is one thing which is advised. Not ill-advised, it is advised for your own good. So intervening snacks, regular meals are a must. Okay? Milk, a very, very common prescription, which is not a good, it is not a good buffer. It's not a good buffer. Why? Because milk, when the effect of milk goes down, it leads to reflex hyperacidity. So milk may not be a good option. So initially when we were taught is, ask the patient to drink a lot of milk, 3 glasses, 4 glasses, 5 glasses of milk throughout the day. Under the false belief, now we know it's false, under the belief at that time, there's a very good antacid. No, it's not. So you can, the patient can take milk, but not with the thing in mind that this milk is going to digest or is going to buffer my acid. No, it's not. But you can take milk. It's not that milk should be prohibited. That's not what I'm saying. What I'm saying is the milk should not be considered to be an antacid. Okay. Now drugs, H2 antagonists still hold forth. There are a couple of instances where you can give H2 antagonists. Why? Because PPI should not be given indefinitely. The best part is that the PPI should be given. I mean, the best regime is when you give it to 14 days and stop. That is the best. But what do we see? We see PPI is being given for months and months on end. It should not be. It should not be. The side effects of PPI is a gastric atrophy, which can occur for a very prolonged use of PPI. Mucosal locally protective agents can be given, but then they are no replacement for a good diet. But nevertheless, you can use sucralfate containing solutions or gels, or you can use magnesium containing solutions. So they can be given, right? So that is the conservative therapy. Now, apart from that, when you talk about the drugs, of course, the H. pylori eradicating drug, they have got a very important role. And among them, we already talked about the PPI, but a better would be a triple therapy, which contains the PPI. No doubt about that. But then it would also contain, yesterday we talked about the triple drug therapy, which contains clarithromycin as the mainstay. So that has to be there. That has to be there. And 2 other antibiotics have to be given, right? Now, stop the precipitating factors. Again, a very important. You've been giving all the conservative we just now designed in the last slide. But if you don't stop the precipitating factor, it doesn't make any sense. It's no use. So stop the precipitating factor, especially the NSAIDs. The old, especially the old age group or even the middle age group, they have a habit of popping these pills into the mouth. They have a headache, you take an aspirin. You have a body ache, take an aspirin. You have a ache in one of your joints, take an aspirin. Aspirin basically means any NSAID, not only aspirin, any NSAID. So that is a frequent usage with reflexly you keep taking without thinking what I'm taking. So that should be stopped. Indiscriminate use of these medicines should be stopped. Stomal ulcers, prolonged anti-secretory agents are required. Zollick Ulcer syndrome, nothing to say. You have to keep PPI long term, with or without the need of surgery, depending upon what kind of syndrome you have. Now, we're not going back to the Zollick Ulcer syndrome. Now, gastric ulcer, what are the surgical treatment options available? Number one, a partial gastrectomy, and that's a Billroth 1 gastrectomy. I'll just show you the next slide what Billroth 1 is. There is a limited resection, 1/2 to 1/3 of the stomach only, and that part which encloses or includes the gastric ulcer, that part of the stomach has to be removed. And then you have to do a gastroduodenoscopy. So basically, Billroth 1 is nothing but gastroduodenoscopy. The mortality figures 2 to 3%, recurrence 2 to 3%, dumping syndrome 20%. We'll come to what dumping syndrome is, and that's not a very good figure. 20% is not a very good figure. It is a poor figure in the sense that it create a lot of problems for the patient. The second option could be vagotomy, but as we said earlier, remember what we say, in a gastric ulcer, it is normal acid or it is hypoacid. So how is vagotomy going to help you? Vagotomy helps you in one sense, that if the patient got normal acid, it will be bringing this normal acid toward the hypochlor spectrum, right? In addition to that, remember, always excision or biopsy of ulcer for higher ulcers, all the elderly males. So if you find a patient who's in the upper age group, old age group, and you find this patient to be having an ulcer, a gastric ulcer, so only vagotomy will not suffice. Either take a biopsy from that ulcer or you excise that ulcer. So that would complete your whole spectrum of surgical therapy for a gastric ulcer. You have to do a vagotomy along with excision, a biopsy, or just take a biopsy. Now this is what Billroth 1 is all about. We'll not be going into the details of this. There are a lot of them. Schumacher, Cockers, Von Berer, Heberer. So this is basically the A is Billroth. See what has been done? This is basically stomach. That part of the stomach was excised. This is what the excision has been done. See, I've excised this. Why? I found an ulcer here. So I do an excision and then I close it. Part of it is closed, and then I take the duodenum and attach it here. See, this part I've attached the duodenum. This is the part. See this part? This part has been closed. That's the part. Now, this closure and attachment could be in various forms, and then we given this name. It can even be done as a part of a jejunostomy, a gastrostomy do and why, which is not strictly a Billroth 1, but Billroth 1, just remember, is a gastroduodenoscopy. Remember that. It will be more easy to remember what Billroth 1 is all about. Okay, now what about the duodenal ulcer? What do you do for a duodenal ulcer? What's the surgical treatment for duodenal ulcer? Now we know for gastric ulcer, if you want to do surgery, the primary has to be partial gastrectomy. Okay, along with excision of that part of the stomach which has the ulcer, and then reconstitution in the form of anastomosing the duodenum to the stomach, right? Gastroduodenoscopy. Clear. Now, what about the duodenal ulcer? The duodenal ulcer has got a number of options available, because here we're talking about a normal or a hyperacid, never low acid. So we have a spectrum of normal to high. Now, what can we do about that? Number one, we can still do a partial gastrectomy to include what? One of the main stimulus for the acid and a part of the acid secreting content. That means this has to be much more amount of stomach has to be removed. Why? Because one, I have to remove the part which is stimulating, that means gastrin, and one, I have to remove the mass of the parietal cell because that is secreting. So it has to be almost 2/3 of the stomach. There it was 1/3 or half of the stomach, not beyond that. Here it has to be more than half, almost 2/3, right? And a 2/3 gastrectomy, and to close the proximal stomach end and perform the anastomosis at a fresh site. Remember, fresh site. It is a new site. That would be Billroth 2. If I don't create a fresh site, I've done the excision, the same 2/3, and at the same the part of the stomach which was cut, to that site, I do an anastomosis, then it will be known as a polyagastrectomy. So nothing different about that. Just remember, the only difference in polya and Billroth 2 is, in Billroth 2, the stomal or the remnant, gastric remnant is totally closed, and the anastomosis of the jejunum to the stomach is made at a fresh site. In polya, it is at the same site. Is that clear? So that's the only difference in polyagastrectomy and Billroth 2. So in this, basically the cut end is closed and anastomosis at a fresh site in this one, and in polya at the same site. Now, recontinuity. How do you establish recontinuity? I'm not taking the duodenum upside. You can't take the duodenum so high up. You have to mobilize everything. So what do I do? What I can do is I can take part of the jejunum up, either as a loop, end to side. I can take a loop, or I can do a Roux-en-Y anastomosis. And there I take a segment of the jejunum and anastomosis. So recontinuity is established in two forms, either Roux-en-Y or end-to-side gastrogenostomy. So that is one where I've decided I want to remove the mass of stomach so that no acid is being produced or the acid production is minimized. How? I would reduce the parietal cell mass, the PCM yesterday we said, mainly in the stomach body and the fundus. I don't have the fundus, I remove part of the body. And I'll also remove the antrum. Why? Because that's the main stimulus, one of the main stimuli. The gastrin is stimulating. So the gastrin is housed where? In the antrum. So I've removed that. So one is excisional, excision of the stimulus and the parietal cell mass. The other could be the stimuli only could be broken. And how do I do that? By doing a vagotomy. And when I do a vagotomy, it will be 3 times. But remember one thing, that when I do a vagotomy, I am also inhibiting what? The peristaltic activity of the stomach. So either I decide to do a type of vagotomy where the pyloric activity is still present. It is allowed to remain. Why? Because if I don't allow the peristalsis at the antrum, what's going to happen? What's going to happen is basically that there would be a complete block at the pylorus. This is a physiological block. It's not an anatomical block. It doesn't relax. It doesn't relax. There's no peristalsis. The pyloric sphincter doesn't relax. So what's going to happen? Obstruction. This is basically gastric outflow obstruction of the physiological type created by me. I did my vagotomy and in my wisdom I didn't do anything else. So what's going to happen? Everything blocked. So if I have to do a vagotomy, either I leave the fibers behind which are governing the pylorus so that it keeps on opening, or if I do a total vagotomy, I have to add a drainage procedure. And that drainage procedure, either I can make the pyloric sphincter incompetent. How can I do that? By pyloroplasty. I cut the sphincter, anastomose, and that will be pyloroplasty. So there's no sphincter, no blockage. So there's no hold up of the content, it will keep on passing. Or I can do a gastrogenostomy. I can do gastrogenostomy. Or else, even for vagotomy, I can combine it with entrectomy. So what I've done, I have blocked the impulse of the vagus. In addition, I'm also going to block the gastrin. Entrectomy means what? The gastric antrum is cut off. So the gastrin is blocked, or rather is removed from the scene. Those cells are removed from the scene. So with a vagotomy, either I do a vagotomy which spares the pylorus from the vagal impulses, that means vagal impulses continue the pylorus, I spare it, or if I cut the whole vagus, I add a drainage procedure in the form of gastroscopy or pyloroplasty, or along with truncal vagotomy, I do entrectomy. When I do entrectomy, by definition itself, the sphincter goes to the antrum, right? So these are the options available. Now let's see what is vagotomy all about. They got two vagus, the anterior and the posterior vagus, right? Now, the anterior and posterior vagus is, the anterior vagus is important in the sense, along with the gastric branches, the anterior nerve of lateral jet. Now, lateral jet is basically the nerve or the part of the vagus which is supplying the pylorus, what's known as the crow's foot. See this part? This is the pylorus. So this part of the vagus is supplying the pylorus. And at no cost do I want these to be cut. Why? Because if I cut these, this activity goes. And I said in the last slide, this activity goes, a physiological gastric outflow obstruction. So I want them to be present. In addition, so basically means what? I'm trying to cut these. If I just cut these, that will solve my problem. If I cut the hepatic branch also, then what's going to happen? These impulses to the, or the impulses, vagal impulses to the whole of the hepatic compartment, to the biliary compartment, to the jejunum, and down into ileum, so on and so forth, they all be cut. Okay. Now, along with this, the posterior has a very important nerve. Why important nerve? Criminal nerve of Grassi. Why the term criminal? For the simple reason that when vagotomy was done, and of course the celiac branch, the celiac branch is basically supplying the structures of the distal GI. See, of the celiac, it goes and supply the jejunum, the ileum, and the colon, and so on and so forth. Now, celiac branch, yes, we know the importance. What about why the term criminal? The term criminal was designed because when they did a vagotomy, they, in the initial stages, let's say about 50s, 60s, 70s, they found that these patients had recurrence of hyperacidity and they had a recurrence of ulcer. And they couldn't understand. They said, look, I've done a very good vagotomy. I've done a very good vagotomy. And still, what do you find? I find the patients are getting a lot of acid. Now, why is that occurring? The parietal cell mass is still being stimulated, and I can't understand what's happening. Now, what happens is that in some circumstances, this nerve of Grassi arises higher up. Okay, rise higher up to supply this part of the stomach. Does it have parietal cell mass? Yes, a lot of parietal cell mass, the fundus and the cardia. and this nerve is arising from here. Now, under normal circumstances, if I do a truncal vagotomy, trunk means what? I'm cutting here and I'm cutting here. See, the branch is coming even here. So if I design to cut it here, I'm sparing these nerves. Similarly, if the nerve of grasp was coming higher up and I chose to cut here, this nerve would be spared. So this was the most common reason of recurrence of a truncal vagotomy of the ulcer disease. Most common reason for a persistence of hyperacidity after the truncal vagotomy. And that is why it is criminal. Criminal why? This is the basic criminal who's still producing the or stimulating the acid. That's why it was the criminal of gastric. Basically, let's understand this much more clearly. So what we are doing is either we are dividing the trunk, including the celiac and hepatic branch, and denervation of the pylorus. So that means if I cut it here, I'll just very good figure for that. So a pyloric drainage procedure has to be added. So if I'm cutting it here, I've cut all this, so pyloric drainage procedure is to be added, right? Why? Because denervating everything. Let's see the next figure. This is basically the highly selective or a parietal cell vagotomy, also known as proximal gastric vagotomy. So three terms, three different terms, and don't be misled by these three terms. May mean the same thing. Ultimately, they mean the same thing. And what these same things, that the nerves of lateral are being preserved. I'm cutting what? All nerves supplying the stomach. All are supplying the stomach. What have I spared? The celiac and the hepatic. They've been spared. So it is denervating the fundus. If I cut it here, I'm also cutting these two nerves. But in HSV and PCV, I'm going to cut this, 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 and this. Sparing what? These two, and sparing what? The nerve of lateral, the anterior and the posterior. So it does not denervate the liver, biliary tree, pancreas, and so on and so forth. And that's why it's also called as proximal gastric vagotomy. Proximal gastric vagotomy. Why gastric? Because I'm only cutting the parietal cell mass supply. Right? As far as HSV and PCV is concerned, this is a very good figure and self-explanatory. Now, the question is HSV and PCV the same? The highly selective and parietal cell, they mean the same thing. But what is essentially different is that in a highly selective, you're deciding from outside what is to be spared. See, spared, spared. You cut what? Supplying the stomach. This hole is the pylorus, being spared. So this is the posterior, the anterior. So I'm cutting all the branches. Selective, total. Is the hepatic and celiac being cut? No, not being cut. When is it being cut? See these two, the truncal. So I'm cutting the truncal, I'm cutting everything. I'm cutting everything. And I would need a drainage procedure. If I'm cutting out here as a selective, I'm cutting here. So that means the whole of the stomach goes, the whole of the pylorus goes, the hepatic and the celiac are spared. So selective vagotomy is, it is selection of the stomach, total stomach, sparing the celiac and the hepatic. Is that clear? That's the term known as selective. That's why the term total gastric. Why? Selection of the total stomach and leaving the extra stomach area, extra intestinal part, which has been left behind. That means the celiac and the hepatic. So you don't cut the celiac, you don't cut the hepatic, the rest of the stomach supply cut, it is selective. Hardly ever done now. Nobody does it. If at all you want to do it, you do a truncal or you do a HSV or a PCV. So what the difference is HSV and PCV? Why two terms? The term is different in the sense that HSV is basically deciding on leaving the nerves of lateral behind just from the serosal landmarks. That means from outside the stomach, you decide. And how do you decide? You decide where the sulcus intermedius is lying. You decide where the vertical line from the incisura to the greater curvature. And any supply to this particular area is not to be touched. So how do you do it? It is very simple. So from that particular area of the incisura, you go right up to the esophagus and you denude the whole of the stomach from its lesser omentum. Just denude it. Just denude it. Keep cutting, cutting, cutting until that particular area is bare. And you make the greater curvature bare. So if you are making this bare, this stomach bare, and this part bare, you're cutting all the supply. And you don't bare this area. This is the area which is coming out here, don't bear it. That is left behind. The attachment of the mesenteric part is left behind. So you will not be cutting the normal latitude. That's one of the simple methods of doing it. Or you can do one more thing. You can do a gastrotomy, open the stomach, and do a pH test of the mucosa. So you do a pH until you find that the pH changes. So this is a highly acidic pH. and here you are doing a mapping and you find this pH is different from this. That is the area to be left behind. So if the vagotomy, HSV or a PCV, if you're doing a vagotomy which is sparing the pylorus by doing a pH estimation, it's known as the parietal cell vagotomy. Why? Because we're cutting the parietal cell supply. That's why the term parietal cell vagotomy. Highly selective is an anatomical term in the sense that from the exterior of the stomach, you decide what to leave and what to cut. Is that clear now? So both mean the same thing, but one is a mapping by pH and the other is basically a serosal decision from outside. That is basically the difference only. Both of them are denoting the area which is supplying, or the nerves is supplying the parietal cell. Okay. There's another term known as medical vagotomy, and that is basically use medicines or vagolytic drugs, right? Now, I said drainage procedure. Now, the drainage procedure, the most common drainage procedure. So, I've done a truncal vagotomy, and in my wisdom, I decide, look, I've done a vagotomy. There's going to be a physiological gastric obstruction, and I should do something. I'm sorry, I forgot to close my phone today. Okay, I'm shutting down. So basically, what is done now is that I am doing. Okay, heel maculus. So I have to do some kind of a drainage procedure. So I choose to cut the sphincter. So that means I have to do a pyloroplasty. So what do? I cut it along the long axis. This is the long axis. Okay, and then I stitch it vertically. This is the stitch. So what do? I make this whole region incompetent. Of course, reflux is going to occur in this patient, but there is no chance of having a hold up of food material. So this is vagotomy with drainage. Okay, this one of the drainage, pyloroplasty. That's one method of doing a pyloroplasty, heel maculus. The other method is that I make a U-shaped incision and then do anastomosis. This is a Finney's pyloroplasty. These figures are taken from Robin Smith. So you can look it up. It's very well depicted. So this is a Finney's pyloroplasty. Now, what I can do, another option is that I don't make a U-shaped incision. I make a separate incision here and a separate incision. When is it required? It's basically required in those circumstances where there is a severe degree of contraction of the duodenum and distortion of the duodenum. So much so that in this particular area is so much distorted that I can't make a incision. So what do? I make a proximal incision in the distalmost part of the stomach and incision in the proximal most part of the duodenum. See, this is the second part of the duodenum, not the first part. Second part of the duodenum, and this is basically a pylorus. So I make two incisions out here and I then stitch together. So this is how it looks like. So this is basically a pylorodudenostomy, right? It's not a pyloroplasty. Have I done anything with the pyloric junction? No, I have not done anything there. So it's not a pyloroplasty. I have anastomosed the pylorus to the duodenum. That's why pylorodudenostomy. So Jabalois is not a pyloroplasty, it's a pylorodudenostomy. That is the important difference. So pyloroplasty is only two. Pyloroplasty is only two, Finney or heel maculus. The third one is a pylorodudenostomy. Is that clear? Now coming to the Billroth that we showed to you, Billroth 1, I already showed you the figure. The second one we said was a Billroth 2, which is the most commonly done. So the two common drainage procedures done after vagotomy, one we either do a heel maculus or we do a gastrostomy. Now when we do a gastrostomy, it's very well depicted out here. I've closed what? I've closed the duodenal end. I've done a partial gastrectomy, and now I'm doing a anastomosis out here. So because this is being anastomosed to what? The cut end. So this will be known as a polya. So this is not a true Billroth, it is Billroth oblique polya. This is a polya. If it had been Billroth, I would have closed this, the whole thing, and I would have made an incision here and then anastomosis out here. So this is polya. So this is the most common type of gastrostomy done as of today. It is a polya gastrostomy. So this end is closed. Now this is the fourth part of the duodenum, and this is the jejunum which is being brought up. So I'm bringing the jejunum up, and this is a loop of the jejunum which is being anastomosis cut end of the stomach. So this is a gastrostomy which is end to side. This is end and this side. So end to side gastrostomy. Now there could be a number of options available to me. Now remember, the transverse colon lies out here and jejunum is in the infracolic compartment. So when I take the jejunum up, either I can take it anterior to the transverse colon or I can take it through the mesocolon. So that could be anterior to the anterior surface or posterior surface, anticolic and retrocolic. So if I want to go posterior to it, I can still anastomose the anterior part, which would be a difficult proposition. So when I go retrocolic, that means I take it to the mesocolon, I would select the posterior surface of the stomach to make anastomosis. So retrocolic is usually as to the posterior surface and anticolic and as opposed to the anterior surface. Now, basically, this is what you see. This is the afferent, this is the efferent. So afferent loop has been taken where? Limb has taken where? Lesser curvature. The efferent, greater curvature. So this is known as a afferent loop lesser curvature. Initially, the terms used were isoperistaltic and antiperistaltic. Now, this is what we meant when we said isoperistaltic. That means in conformity with the normal peristaltic flow. The normal peristaltic flow will be coming from there. The gastric pacemaker, okay, coming out here. And where will it go? It will go like this? No, it will go like this. So this is isoperistaltic. Even the secretion from here are following the normal peristaltic activity. So this is basically a isoperistaltic type of anastomosis, which should now be known as a afferent loop lesser curvature, efferent loop greater curvature. Is that clear? Now you could have a reversal also. If you have a reversal, the efferent loop goes here and the afferent loop goes here. So you're basically twisting. When you're doing a twisting, this would be known as a retroperistaltic, which is not a very good option. So it should always be afferent loop lesser curvature, isoperistaltic. It should be either anticolic or retrocolic, and you use the anterior surface or the posterior surface for anastomosis. Is that clear? So that's how you describe a Billroth or a Polya gastrectomy. Now, among all these surgeries done, available, let's see what are the results. And that's how we decide which surgeries to be done. So among the options available, we had a gastrectomy, your gastrojejunectomy, right? You have truncal vagotomy drainage, a selective vagotomy drainage, highly selective vagotomy. Why in red? Because it's the most preferred gold standard now, and truncal vagotomy and entrectomy. But what I have some more red colored. Now, if you look at the recurrent ulceration, see the lowest or the best figures are provided truncal vagotomy entrectomy and gastrectomy. 1 to 4%, 1%. Best figures, right? But at cost of what? Look at the morbidity, 10 to 20%. Look at the morbidity, 20 to 40%. So is it worth it? It's not. And that is why both all the features taken together. In addition, 1 to 2% mortality. Here 1% mortality. Now, if you take it and compare with a procedure which has got uniformity in all the three departments, that means operative mortality, significant side effects, and recurrent ulceration, if you have all the three together, less than 0.2, less than 5, and 2 to 10. So that is why it is giving almost good results, as good results as for recurrent ulceration as the other two. It is going very good results, or rather the minimal side effects and the minimal operative mortality. And that is why highly selective vagotomy is the gold standard of vagotomy as of today when you want to do a surgery for a duodenal ulcer, right? Now comes the important part, and that is what are the peptic ulcer sequelae. Now if you look at the peptic ulcer sequelae, these are very, very important. Why? You've done a surgery and you're very happy about it, but the patient keeps coming back to you with a lot of problems. Number one, secondary to gastric dissection. And number two, secondary to gastric reconstruction. And number three, post-vagotomy. And number four, malignancy. Now, the first one, secondary to gastric resection, I'll be going slightly fast because a lot of ground to cover. Secondary to gastric resection, dumping syndrome, early or late, and metabolic. Okay, that's secondary to gastric resection. Secondary to gastric reconstruction. I've done reconstruction, I can still have complications, which are not because of resection, but now my faulty reconstruction. Afferent loop syndrome, efferent loop syndrome, alkaline reflux gastritis, and so vagotomy, post-vagotomy syndromes, diarrhea, atonia or gastroparesis, incomplete vagal transection, where the criminal nerve gracia has been left, or you cut or you left some fiber of the trunk itself. So that's incomplete vagotomy, and gallstone formation over a period of time. And of course, last one, the malignancy, which can appear 10 years later, 4 times incidence as compared to the normal population, right? Dumping syndrome, the early dumping syndrome or the late dumping syndrome are now believed to be because of the same pathology, same spectrum pathology. So what is the pathology? It occurs 1% after HSV minimum. We just refer to that chart that we had. 10 to 50% after partial gastrectomy, especially Billroth 2. That is very high, right? Dumping syndrome. And common symptoms treated with early gastric emptying. Number one, right? So what are the points to remember? Number one, high osmolar gastric contents reach the jejunum early. Now, normally it should go through the pylorus into the duodenum in the process getting digested until it reaches the jejunum. Now, what's happening? Undigested food. You have something, immediately the jejunum is loaded with it. And that is the high osmolar content, not being digested at all. So, high osmolar gastric contents into the jejunum. Number two, transference of fluid across the vessels into the lumen. Why? You have a high osmolality inside the lumen. Higher than what? Higher than the vascular osmolality, which is 290 to 310. So what's going to happen? Fluid transference. Why? Because high osmolality will drag out fluid towards itself. So transfer fluid across the vessel to the lumen, leading to what? Symptomatic hypovolemia. Third thing, because the load on the jejunum is suddenly very high, so there has to be a intestinal distension. Intestinal distension, a very important thing to remember. So the jejunum is going to distend than what it's normally supposed to do. Why? Because now it has to take care of a very large load from the stomach immediately without a digestion. So the jejunum distends. Number 4, peptides released in response to the intestinal distension is very important. That's very, very important. So that distension in turn leads to what? A peptide release. And these peptides are what are believed to be the primary responsible for vasomotor symptoms rather than the high osmolar contents, right? So it is probably the distension mediated peptide releases. Okay? The fifth thing to occur, so there are 4 things occurring. The fifth is a reactive hypoglycemia, 2 to 3 hours later. And this is also part of the dumping, but this is what's responsible for the late dumping. Now you had a food, a high carbohydrate diet inside because you take a normal diet. A normal diet almost always has a high carbohydrate content. Now that high carbohydrate content went where? Into the jejunum. Now that stimulated what? Insulin release. Why? Because the carbohydrate had to be digested. Now it took care of the digestion immediately, but then what happens? Suddenly what do you find? You find this hypoglycemia. So there is a sudden outpouring of a high insulin output causing hypoglycemia as the end result. Enteroglucagon is also outpouring because of internal distension, leading to what? An increase in the insulin, ultimately hypoglycemia. So both of them would be causing hypoglycemia over a period of 2 to 3 hours post-parenteral, leading to what? A severe degree of hypoglycemia, which is primary responsibility or primarily responsible for the late dumping syndrome. Okay. Now most of these are self-limiting; they resolve within 3 months. And if you do some conservative care of this patient, take certain strict precautions, you don't require any kind of treatment, right? So you take dry meals, you take decreased carbohydrate because these are what's happening. If a lot of water leaves a lot of distension jejunum, so take dry meals, less of water. The food doesn't swell up, so less of osmotic load. So dry meals, decrease carbohydrate, decrease the fluid intake. 90 to 95% benefit just by decreasing the fluid intake. To in between meal. So take a dry meal and take the dry meal again. In between, take some fluid. Okay. Avoid extra salt. Octreotide acetate, which again I said somatostatin, it's basically analog. Somatostatin is I told you depression, total depression. So you also potent long-acting somatostatin analog. It blocks the peptide hypersecretion. It's going to block everything. Block everything. Surgery can also be used, and how can you do that? Because remember, it's occurring after what? Gastroscopy, occurring after what? Pyloroplasties. So you can reverse those procedures. So gastroscopy can be substituted, pyloroplasty can be substituted, change the procedure. You go ahead and do surgery again, but not usually required. Why? Because most of them are self-limiting 3 months. Or you can do a 10 centimeter reversal of jejunal segment, interpose the gastrocule. So what you do is, the one thing which I can tell you is that you can do a antiperistaltic. What is antiperistaltic? The efferent limb, not to the greater curvature, to the lesser curvature. So the afferent limb to the greater curvature. So here instead of this, suppose if I take this limb and go here, and this limb here, what is going to do? This is antiperistaltic. So that means whatever content comes here is going to take a longer time to reach this limb. Why? Because if this limb is lying out here, this will fill up, and only then be drained. Only then be drained. So a longer waiting period in the stomach is achieved, which would lead to taking care of the dumping syndrome. So either do a reversal of jejunal segment, or you can do a reversal of antiperistaltic. The second thing I can do is, suppose I have this, no doubt, but after this, let's say 15 centimeter, I cut this out. I cut out a 10 centimeter segment and I reverse it. That means what was lying distally, brought proximally, what is not proximal, brought distally. That means I'm twisting it. So reversal of this segment. So what is better? This is better. I'm making an anastomo as it is. So why not make this anastomosis with this limb going to lesser curvature? So that is efferent loop lesser curvature. Instead of afferent loop lesser curvature, I will do efferent loop lesser curvature. Is that clear? So that is one of the treatments which is advised for dumping, whether it's late or it is early dumping. And entrectomy with Roux and Voy is another option available. right? So this basically, if you look at the comparative chart, both of them are about 5-10% incidence. Relation to meal, I told you, almost immediate, and second hour after meal. Very easy to understand because reactive hypoglycemia would be occurring only some time, take some time. Duration of attack almost equal, 30-40 minutes, 30-40 minutes. Relief just by lying down. Here, hypovolemia is at play. In early time, what's happening? Transfer fluid. I feel faint. I feel faint. I feel as if I'm going to go down. So I lie down. If hypoglycemia, I take a lot of, I just take a teaspoon of salt, of sugar. That takes care of it. Why? I'm taking care. Switch your mic off, please. So relieved by food, aggravated by what? More food and exercise. Respirating factor, food, especially carbohydrate rich and wet. Here, it is mainly the reactive hypoglycemia. Major symptoms in early dumping, epigastric fullness, sweating, lightheadedness, tachycardia, colic under bacterial, all as a result of what? Increased peristalsis and increased hypovolemia. Here, tremor, faintness, prostration because of what? Hypoglycemia. So it's nothing to just memorize, it's just understanding the whole pathophysiology. A post-vagotomy diarrhea seen in 2/3 of the patients after truncal vagotomy. They experience a change bowel habit. Not really diarrhea, but change bowel habit. But it subsides generally within 3 months. So again, the first one was subsiding 3 months. This also will subside within 3 months and take care of those 3 months. But 5% of these would be persisting as a chronic post-vagotomy diarrhea in 2 forms. So you have 2 forms of post-vagotomy diarrhea, which are really going to trouble you, but that's only 5% of the patients. And what are these 2 forms? Number one, I have continuous only water stools failing. I go for defecation, found watery stools, day in and day out. Persisting months on it. I become dehydrated, I have hypertonia, and so on and so forth. The other episodic, I have severe pain, immediate pain, immediate attack, I have a diarrhea, disappears 1 to 2 days. So that is in half the patients, you know, intermediate attacks and associated pain in about half the patients, continuous in the other half. So the 2 forms of post-vagotomy diarrhea. And what is the reason? Not very difficult to understand. Bacterial colonization of upper intestine, number one, because the bacteria was supposed to be taken care of in the stomach, the bacteriostatic activity of the gastric juice. But it is now thriving there and is dragged down into the stomach. So bacterial colonization of upper intestine by those bacteria which are never supposed to colonize it, right? But because the stomach is not acting up, it is being colonized because of the drainage procedure. Number 2, structural abnormality is now becoming unmasked, and that is non-tropical sprue, unmasking of non-tropical sprue. That's one. Number 3 is lactose intolerance. People with lactose intolerance. Vagotomy causes a decrease in the lactase activity. So because that decreased lactase activity, the lactose is not being broken down. So there's an increased lactose unhydrolyzed, osmotic effect resulting in distension, cramp, and diarrhea. So either I have an unmasking of non-tropical sprue, or I got a lactose intolerance because the lactase is not being secreted in the required amount. So that means the lactose not being broken down, it is osmotically active, so it's going to give rise to diarrhea. But perhaps the more important reason for this is that there is a decrease in the exocrine pancreatic secretion. Remember, the vagus was doing what? The vagus was also supplying fibers to the pancreas. But now that fiber is gone. So the pancreatic secretions are all decreased. So there is steatorrhea. Stomach contents rapidly pass into intestines. So you have the symptoms because of dumping syndrome. And that's why they say that probably they have got a common pathophysiological mechanism, the dumping and post-vagotomy diarrhea. In addition to this, there's a division of the hepatic fibers. The hepatic fibers were cut, division because of which there's a flabby distended gallbladder and CBD. So they hold up the bile, and then suddenly that large volume is pumped into the flooding the duodenum and the part of the distal bowel, that means the jejunum and the ileum. So that increased bile salt, which is now swamping the denervated small bowel onto the colon, would be leading to what? A decreased water absorption. Result in diarrhea because of defective micelle formation. So that is all going to be the end effect. So the reasons, basically, just remember: colonization, unmasking of non-tropical sprue, lactose intolerance, decreased exocrine pancreatic secretion, the vasomotor because of increased osmotic load to the bowel, and the defective supply to the gallbladder leading to swamping of the small bowel because of high bile acid and bile salts. Now, the treatment, again, not very difficult. Meals, consume liquids between meals, just like in dumping syndrome. Take a solid meal, in between, drink water. Symptomatic, take antipasal, Lomotil, codeine. This will basically help you in holding the fluid up for a longer period of time, so the content for a long period of time, so that absorption occurs. Now, that is not going to lead to a rapid transit. So it retards the transit time. Persist even after 6 weeks, see for special causes and treat them accordingly. But normally by 6 weeks, they should disappear. Lactose intolerance, you have to modify the dairy product that you're taking. Gluten enteropathy, celiac disease, you have to give oral antibiotic, diet modification. Polytyramine basically will take care of the increase on bile salts and bile acid which are swamping the bowel. So take cholestyramine or like substances. And surgery, if none of them are helping you out, then you do a reversal as we're talking about the 10 to 15 segment reversal of a segment of jejunum, which should be placed 50 to 100 centimeters distal to the ligament of teeth. That means if there's a ligament teeth, that's the third part of the duodenum, the fourth part, and ligament teeth out here, the jejunum coming from here. So from 50 100 centimeters from this part, let's say it's 50 100 centimeters, I take a segment 10 to 15 and I reverse it like this. So reversal of that segment of jejunum from 50 100 centimeters beyond ligament teeth, and the segment should be about 10 to 15 centimeters. Is that clear? Now, metabolic disturbances seen. Number one, anemia. Iron deficiency anemia, usually because of decreased intake, decreased absorption, chronic subclinical gastric mucosal bleed because of mucosal irritation at the anastomotic site. They all combine to give some degree of iron deficiency anemia. Pernicious anemia, yesterday I told you, would be because of vitamin B12 deficiency, decrease of intrinsic factor, but that would take 3 to 7 years and usually seen most commonly after total gastrectomies, and then you have to replace the vitamin B12. Decreased fat absorption, I told you decrease exocrine pancreatic secretion. So mixing of pancreatic lipase and bile salts with dietary fat less, the miscellaneous formation is less. So it bypasses a lot of fat. So we're passing bulky stools because a lot of fat coming out of the stool. So steroid. Osteoporosis, osteomalacia, decreased calcium absorption, all because of the fat in the lumen binds to the calcium. So increased fat in the lumen is now binding more and more and more calcium. This fat is not supposed to be there. It should already have been digested. It's not digested because decreased exocrine secretion of pancreas. So that fat is as such will now start binding to calcium. So it leads to a lot of orthopedic problems. And then of course, weight loss or partial gastrectomy is again the eventuality. Other complications, gallstones after fungal bigotomy. Why? Because the bile spaces in the gallbladder. The bile is there for a longer period of time. So there is sedimentation, there is condensation and formation of stone, giving rise to a gallstone formation. Right? Malignancy 10 years after a partial gastrectomy or a truncal bigotomy drainage procedure. 10 years later, you can expect a malignancy, 4 times the risk as compared to a normal person. Biliary reflux, and we all know why it occurs. You have cut the bowel sphincter, dismantled the whole apparatus. So from the duodenum, it's coming back into the stomach. So you have a biliary reflux. With this biliary reflux, there's damage to the gastric mucosa, often leading to intestinal metaplasia and gastric cancer. That is the reason why you have an increased gastric cancer in these individuals. A small stomach syndrome, loss of receptive relaxation, improves with time. Because remember, even with diaretic, what is said, that if you keep on eating, you just have 50 to 30 ml of stomach remaining with you after they're done away with the rest of the stomach in a roux and wine, right? Now, you're very happy that I only got 15 ml, I can eat anything. Don't do that. 5 years, the stomach enlarge. Yesterday, anatomy of stomach, what did he say? It can increase to 75 times. 75 times. So even that 50-30 ml can become almost 250 ml of stomach volume. So if you keep on eating, similarly out here with the passive time, it improves the time. Why? Because that small stomach left after partial gastrectomy, you have left a small amount of stomach that will increase in size with time, and the receptive relaxation will start occurring, and then those dumping syndromes and all those would stop occurring, right? Recurrent ulcerations and gastrojejunocolic fistulas are other complications which can occur because of the breakdown of anastomosis in a particular area, which burrows into the adjacent colon, and these patients come up with gastrojejunocolic fistula. This is basically a manifestation of a failed gastrojejunal anastomosis, which is limited by the colon. You don't get the generalized signs, and because the colon is limited, the colon is eaten away, that particular eaten away, and it burrows into the wall of the colon, and then you get a colon jejunal gastric fistula. Stomach, jejunum, and now burrow into the colon, right? So that's basically a fistula, which is a major part, a major problem. Afferent loop obstruction is again an important, it's an important complication. And here what is happening is either is kinking, herniation, and volvulus. And that is when the afferent limb is more than 30 centimeters. Now let's refer to that figure again. Now this is a limb. Suppose if you leave a long limb, instead of this, suppose a limb is coming like this, and then you're anastomosing it. So if you design a longer afferent limb, like a loop, what's going to happen? It can always keep on twisting. If it is stretched, not very tight, just enough, stretching is just enough, then it's hardly going to twist. But if you leave a larger length of the afferent limb, that is going to create problems. And the most common reason for afferent loop syndrome is a long afferent limb left behind. So if you have a long afferent limb left behind, that can always lead to a afferent loop syndrome. That's why, see, when the afferent limb is more than 30 centimeters, that is the ideal place when afferent loop obstruction can occur. And that is occurring where? At the gastroscopy site. I just showed you that figure. At the site, the obstruction will occur. And what form? Either interception of that limb into the stomach, that can create a problem, or fibrosis, ulceration, or recurrent tumor formation at that particular site. And it occurs in two forms. Number one, this afferent loop obstruction, acute or chronic. Acute for close obstruction that leads to what? It leads to emergency situation, severe abdominal pain, shock, abdominal lump, and early perforation. After all, we only got that limb, that afferent limb, which is now blocked on both ends. One the duodenal end and the other at the stomach end. So that forms a closed loop. This tends, right? So basically, when you have that kind of a limb, you can easily have a blowout in that condition. And that's why early perforation. Severe pain, why? Distension of that closed limb. So shock, again transference of fluid. So abdominal lump. Chronic, it is a gradual obstruction, so it can occur any time after gastroscopy because there is partial obstruction of the afferent loop. And so postprandial discomfort, pain, pent-up biliary and pancreatic secretion are there, so it creates pain, gets released into the stomach, so everything is all right. So in chronic, it is gradual. In acute, it is sudden, right? In these conditions, when it is released suddenly, there's sudden projectile bilious vomiting without food particles. After what is being released from the afferent limb? What's being released? What is it being released? The duodenal content and the pancreatic content. So it has to be bilious. So projectile bilious vomiting without food particles with dramatic relief and symptoms. Prevention, make that afferent loop less than 20 centimeters. Just stretched out, that's all. Not too tight. Not tight that it breaks the anastomosis. No, it should just be stretched out, right? And do a retrocolic bilirubin or poly. Retrocolic basically means take it through the transmesocolon. If you do that, it is slightly better. Why? Because it is going through the transmesocolon, it not allow it to twist. Because one holding point with the transmesocolon. This is the colon, transmesocolon, stomach is here. So either I can bring it like this or I can bring it like this. If I bring like this, it's being held up even the transmesocolon area. So it will not be allowed to twist. Here everything is everything is free. So a retrocolic bilirubin 2 with afferent loop less than 20 centimeters is the answer to prevention of afferent loop obstruction. Treatment emergency, and what can you do? You can do afferent deferent anastomosis. After all, this is a stomach and the loop is coming like this. Loop is coming this. So if I anastomose these two loops, the afferent and so this is the afferent and this is the efferent coming out from here. So if I anastomose it out here, what's going to happen? Even if there's obstruction there with the afferent limb, it will be taken care of by the bypass out here. So emergency afferent efferent anastomosis. Elective, you can do a Roux-en-Y gastroscopy instead of the loop, which can have the afferent and the efferent loop. Here I don't have any loop. I do a Roux-en-Y. So I just have one single loop coming, or not even loop, one single segment of the intestine going down. Efferent loop obstruction, where is it occurring? To the limb, which is coming from the stomach, afferent, efferent. It's coming from here to the rest of the bowel. So any cause of small bowel obstruction could be working for afferent limb. So similar to any other cause of proximal small bowel obstruction could be working for afferent loop obstruction, right? Causes could be adhesion, herniation, interception, band, etc., etc., etc. So treatment, treat the cause. Afferent, efferent, pexy to the abdominal wall. Pexy basically you all know means surgical fixation or suspension. That's the meaning of the term pexy. You can attach it anyway. Gastropexy, cecopexy, sigmoidopexy, etc., etc., etc. So you can do a pexy to the transfer mesocolon. You can do afferent, efferent pexy to the abdominal wall. That means when you do it So this is the stomach coming like this. You run anastomosis, fix everything to the anti-abdominal wall. So when you do a FND, you fix it this abdominal wall fixation, this cannot move anywhere. So you can do a different PEC to the abdominal wall. You can do a PEC to transmesocolon, or you can even do a different anastomosis. Right? Complication of ulcer diseases are very important. I'll just take about 15-20 minutes, has to be completed. Decreasing out of frequency, hematemesis melena, perforation, gastric outflow obstruction, penetration of an ulcer, and malignancy. The initial ones are very important. Hematemesis, look at the cause of hematemesis. Erosions, 26%, ulcer 6%. So together, the ulcer disease, as you would like to call it, the ulcer erosions plus ulcer, they make up the major amount of or the major causes for ulcer disease. The gastric and duodenal ulcers are the both, and the duodenal is more common, see 33%, right? The esophageal varices, which we thought was one of the very common causes, is not. It is only 4%. That is basically the total figure. And then the Difflois disease, the Mallory syndrome disease, they are all, I would say, less common. I would say rare, less common causes. So among all these, the ulcer disease and the erosions are the commonest causes for hematemesis. So what do you do when a patient comes to you with hematemesis? The first thing is don't wait for the diagnosis. Immediately going for management. Initial hemodynamic management is very important. Assess the patient hemodynamically. Try to prevent the blood pressure and the cardiovascular parameter under control. Only then try to look for the cause and try to stem the bleeding without thinking where it's coming from, if possible, at the EHC. So if the patient requires blood, when? Because there is more than 30% blood loss, start arranging for blood transfusion. So hemodynamics, stably to maintain, manage it, arrange blood if you feel that there has been loss of blood to the tune of 30% the blood volume, and only then, once you have this, then on the basis of the history, or if required, urgent investigation, try to diagnose the cause. The past history is very, very important, can always tell you, or could be a very important indicator of the cause. Like for example, patient is having in the past, he had jaundice and he had the vomiting. Immediately what comes to your mind is probably this patient having hypertension. Or the patient says, I've been having epigastric pain since a couple of months or a couple of years. Immediately what comes to mind is probably ulcer disease, right? And then you can decide once you have the diagnosis by either doing a history to be followed by investigation. If possible, early endoscopy may not be possible in every case. Why? Because remember, a lot of blood inside the stomach. You can't hardly see anything. So the thing is that you have to evacuate the stomach of all the blood and then do a OGD. And once you do a OGD, if it's possible, if you're fortunate enough to have a diagnosis, you go in for early conservative or surgical management. But the usual scenario is not so fortunate because doing an early and a decisive OGD examination decision making is not always possible in the whole scenario, right? So if you have the age is again a pointer. If you have it as an older patient, take a history of NSAIDs. That is again a pointer, probably having bleeding from erosions. And you're doing a OGD, it may show an ulcer overlying the duodenum, the lesser curvature, greater curvature. Immediately suspect those three vessels I told you about: the gastroduodenal, the left gastric, and the splenic artery. Now, the high risk of rebleed, this patient who has an OGD, if you find that there's active hemorrhage on OGD examination, 90% risk of rebleeding. Visible vessel, 50% risk of rebleeding. Fresh overlying clot, 30% risk of rebleeding. So that OGD is also, it can prognosticate. It can tell you that, look, this patient is probably going to have a rebleed. Why? Because I'm able to see a pulsating vessel in the floor of the ulcer. That's going to rebleed. So these are basically percentages. But then what you can do is there are risk stratification criteria, which gives a clinical pathological score, and two which are there in the books. I think hardly anybody does it. The Blatchford score from 0 to 23 and the Rockall score 0 to 11. So these are very good scores. They are clinical pathological scores, and they can help you to decide what should be done and to prognosticate. You can easily, on the basis of score, you can even prognosticate that, look, this patient will have a turbulent course, a patient will have this kind of eventuality in the end, or he's going to be saved, or whatever. You can prognosticate these patients. So it is both a therapeutic and a prognostic, both of them, right? That's why therapeutic prognostic risk stratification. It can also help you prognosticate. Now, immediately what you can do is with a nasogastric tube through, you can use medical PPI, antacids, and of course local hemostatics are a major role to play in these patients, right? Melena indicates a longer duration of this. That patient has come to you with bleeding, and you take a history. If we say melena was there, that basically means this bleeding was there in a lesser volume 2 or 3 days back. That is again an indicator in deciding our diagnosis, right? Presence of shock, I said hemodynamic has to be taken. Early OGD for diagnosis, we all know that. Now, if the patient is bleeding from an ulcer, we're talking about ulcer now. I'm not talking about the general hematomas spectrum. If the patient bleeding from ulcer, 75 to 80% would stop bleeding by themselves. Spontaneous resolution just by your conservative therapy of maintaining the blood volume or trying to drain everything out from the stomach and putting local hemostatic or antacids, 75 to 80% would be controlled bleeding, right? 75% of the remaining, they would stop bleeding with PPIs and nilotinib. The rest, right? So spontaneous bleeding or 75% remaining by your conservative methods. Now, if not, then endoscopic intervention may be required. And the indications, number one, a rebleed or a continuous bleed. Two scenarios: continuous bleed, do OGD, see the site and deal with it accordingly. Or the patient has no bleeding for 24 hours and then subsequent to that, he again bleeds, right? So what are the options, endoscopic options, which are very, very important options, and that is in fact the mainstay of treatment of persistent bleeds, hematomesis as a result of ulcer disease. Number one, injection therapy. What do you inject? Epinephrine in a 1:10,000 dilution, or you can inject even with absolute alcohol. Or now what are available are basically local hemostatic agents in the form of polytoconol and light trans, right? Coagulation therapy can be performed with a heater probe, a bipolar succumactive probe, or a gold probe. Three types of probes available for the OGD diathermy or coagulation therapy. And if you combine both, then probably, and then of course pressure can be applied over the area which is bleeding along with the heater probe. That will be coactative coagulation. That means you're pressing to cause coagulation. So if you combine number one and number two, which is probably a better, that means you inject and you coagulate. So combination therapy with the above two is probably the best option available. That means epinephrine injection followed by thermal coagulation appears to be more effective than monotherapy, right? And especially in those cases where you have visible vessel or active hemorrhage or adherent clot. These are, remember I told you, these are the three conditions which are going to rebleed, 30% to 70%. Okay. Now, hemoclips can be used. Several clips will be needed to approximate the gastric ulcer folds, and then you try to oppose the fold. So in the floor of the ulcer, you find that there is a bleed. You apply hemoclips to it, and over the margins of the ulcer, you try to approximate them with the help of several clips. The again hemoclips. So if you can endoscopically, it is possible. If you're good endoscopist, you can do that. So you drag the two edges together and you close the floor of the ulcer by the mucosa, overlying mucosa, right? Transcatheter embolization can be useful. You see this vessel bleeding, a very large bleed, then going for a transcatheter embolization of the vessel. Again, a domain for the radiological endoscopist who puts in this catheter, tries to decide, I've reached the left gastric artery, a very difficult proposition. He has to do the celiac, then he can do the transcatheter embolization. Or you can use an argon plasma coagulation. So all these options are available if you want to treat this patient endoscopically. Okay, but if you're not able to do it endoscopically, or if the patients got uncontrolled rebleed on conservative endoscopic therapy, hemodynamically unstable amount of blood transfusion required is more than 4 units to 24 hours. That these are important definitions, not just to be brushed off. Hemodynamically unstable basically means if more than 4 units in 24 hours. There's a patient more than 65 years of age, is not going to stop bleeding. Why? Arteriosclerosis. The vessels are not going to contract. So this patient is going to have no spontaneous stoppage. He'll be having rebleed again or continuous bleed. Chronic history. The patient has been a smoker. This ulcer has been there for the last 5 years, 10 years. We expect this patient to stop bleeding? No. OGD, you find that the ulcer is where? Over the posterior surface of the duodenum. Gastrointestinal arteries underneath. On the greater curvature, splenic arteries underneath, or the lesser curvature area of the left gastric artery. Now, you don't treat these things lightly. These are the patients. These are the indications where you don't wait for even injection therapy or OGD management of these. There you have to go in for a open surgery or major surgical intervention. Major, what I mean major is basically not endoscopic or other surgery, which could be laparoscopic or it could be open surgery. And earlier the intervention, the better it is, really less more. So remember one thing: more than 4 transfusion, 24 hours, 65 years of age, hemodynamically unstable, very difficult to maintain him dynamically. When you say hemodynamically unstable, are you going to operate? You have to. You have to. Because otherwise the patient will go. So even a hemodynamically unstable patient, you have to intervene in those patients. Chronic history, intervene. Failed OGD, you have to intervene. So there are special and specific criteria when you have to go in for surgical therapy, right? So if you have a duodenal bleed, better would be to do an open. You cauterize the whole of the duodenal C and you go posteriorly. There you have the gastroduodenal artery. Press upon it. Press upon it. The bleeding stops. At the same time, do a longitudinal duodenoscopy. And in front of you, what is lying out there? What is lying out there is this is what is lying. So this is a longitudinal duodenectomy. What is this? Gastroduodenal artery lying underneath. I have a finger from here and I'm pressing on this artery. You see this opening? Very clearly see. So I apply sutures over it. One proximal, one distal. And then I'll stitch this vertically. So transverse across the axis and then vertical across the axis. That's how you deal with it, right? So duodenal bleed, I would be either controlling this with two sutures out here, or else what I can do, I can have underrunning sutures. I apply start from here and keep underrunning them. And I try to approximate these two edges. So I underrun or clip or coagulate and underrun, right? Close it not me, transverse. Gastric bleed, similarly, but here what could be different is I'll excise the whole ulcer. But in excision, I have to be very, very careful that if there's an underlying bleeder out there, the left gastric artery, I'll have to control it. I'll very difficult to control left gastric artery if you don't have prior control over it. So just excising as randomly, look, I'll do an excision, bleeding, let me excise. The moment you excise and the knife reaches the left gastric artery, you have had it. That patient is hemodynamically unstable as it is, and now you lose blood when you cut through the left gastric artery. So very, very careful. First, control the gastric artery. That's the most common site, the lesser curvature. If it's the splenic or the lesser curvature, even more difficult. So that is why this surgery is one of the most dangerous surgery in the sense it is very tedious, has to be very, very careful, and early control of vessels has to be there. Right? So if you just do an open gastrotomy and if you control it over the floor, that is the best option available. Do a gastrotomy or do a duodenotomy, depending on whether you have a duodenal ulcer or gastric ulcer, control it over the floor, and then you do underrunning and close or approximate, right? Now, second is pyloric obstruction or gastric outflow obstruction. I think just two more complications remaining. Take a 15 minutes more. I think we already have 1.5 hours. So term is a misnomer. I pointed that out. Why? Because even we have duodenal obstruction known as a gastric outflow obstruction. So let that name stick, and it's usually basically because of initial edema and later on fibrosis. In the pre-pyloric obstruction, in the pyloric or the duodenum, there has to be spasm and fibrosis. So initial spasm with edema and long-term cicatrization. Symptoms are very, very clear. The periodicity of pain has not disappeared. It is a persistent pain. And persistent pain in the sense that the moment you eat, it becomes a pain as if something is standing or bursting, becomes a bursting pain, right? So epigastric fullness is much more at the end of the day. And vomiting occurs, and what is very specific vomiting, projectile in the initial stages, non-bilious. Why? It is duodenal pre-pyloric and foul smelling. Three very, very important things about this vomiting. Projectile, non-bilious, foul smelling. Why foul smelling? Because the distended stomach is holding the contents which had been taken or ingested 2 or 3 days back. Putrefaction has occurred, and that's why very, very foul smelling content. So projectile, non-bilious, and very foul smelling content as a result of gastric outflow obstruction. Examination, what do you find? You find a distinct fullness in the epigastrium, and you're fortunate enough to tag these patients early, then you can see the visible peristalsis going from the hypochondrium on the left side to the right hypochondrium. You can see these peristaltic waves. So visible peristalsis from the left hypochondrium to the right hypochondrium. Okay, succussion splash can be heard. And how do you define succussion splash? It's a gastric splash or a splash or a slashing sound, right? A slashing sound is basically heard through a stethoscope. It has to be through a stethoscope, not by your naked ear. So the stethoscope has to be where? Over the epigastrium. And you have to shake the patient up. And how do you shake the patient up? You hold the patient with the lower part of the rib. So this has to be, that's how the patient has to be moved. Or the second fixed bony point could be, you can move the patient with the hip bone, that's the iliac crest. So either you make the patient move with the body of the patient move with the iliac crest, or better it is to the lower part of the costal area. So the lower part of the rib cage, you try to shake the patient up with that, and a full stomach, you hear that sloshing sound, splashing sound as you make it when you go through the water. You can hear feel the splashing sound, right? So that is heard, and that is because along with the fluid, there's also air. So until you have air and fluid, you will not hear this sloshing sound. That's very characteristic of a sufficient splash. Degree of obstruction can be assessed by the Bere meal, which is retained after 6 hours, confirmatory for gastric outflow obstruction. Remember, yesterday we talked about the motility study. A saline load test in early stages is very, very beneficial. The patient has come to, let's say, just within 1 or 2 months, that visual peristalsis is not there, but the history is very typical. And you tell this patient a gastric outflow obstruction. So what can you do? You do a saline load test. How do you do it? Empty the stomach first. 1. Number 2, 500 ml of 0.9 saline. Saline. 2. Number 3, clamp 30 minutes. Number 4, re-aspirate. Simple. Empty, inject, and then clamp, and then re-aspirate. Right? So I empty it, I push in 500 ml of saline, I clamp it for 30 minutes, and then why do I give this 30 minutes? For the fluid to move out. Remember yesterday, what did we say? 50% of the egress within 15-20 minutes. Right? But what do I find? When I re-aspirate out 30 minutes of clamping, what do I find? I find 200 ml is still remaining behind. That is abnormal. But if 400 ml is lying, being aspirated back, it is confirmed. So that is a saline load test for you. 500 ml pushed in. After 30 minutes, 400 ml being re-aspirated, confirmatory of early gastric outflow obstruction. Electrolyte abnormalities are to be seen. We have hyponatremia, this vomiting leads to dehydration. So basically, fluid loss. Number 2, all kinds of electrolyte loss. Which one? Sodium, hyponatremia, potassium, hypokalemia, chloride, hypokalemia, and hydrogen ion alkalosis. So what do you have? You have a hyponatremic, hypokalemic, hypochloremic acidosis along with dehydration. Very clear about gastric obstruction. But then you have a paradoxical aciduria. I think all of you know that because we repeatedly being stressed, and you all know that basically initially the patient is using sodium, patient is using hydrogen also. Initially, the priority of the body is to retain the hydrogen ion. So what is happening in distal convoluted tubule? The hydrogen being at the distal convoluted tubule, 3 cations are in play: sodium, potassium, hydrogen. They interplay between each other. If you shunt one out, the other has to be brought in. So if you shunt sodium out, hydrogen. So if you want to retain something, you shunt something out. So if you want to retain hydrogen, you shunt sodium, potassium out. You retain sodium, you shunt potassium and hydrogen out. It's as simple as that in the distal convoluted tubule. So initially the priority is what? Initial priority is hydrogen ion retention. So you're shunting sodium and potassium out. But there comes a time when the hyponatremia becomes life-threatening, below 120 milliequivalents per liter. Remember that 120 is the cutoff point. So when the body is faced with this dilemma of acid-base imbalance and hyponatremia of life-threatening proportions, it selects simply hyponatremia. Look, I have to maintain the value of the body. I have to retain sodium at all costs. If I let the sodium go, severe hypovolemia, and I'm going to die. That acid base not going to make any difference. The body going to do. So I have to retain sodium. So if I have to retain sodium, and the distal convoluted, I told you 3 interplays: sodium, potassium, hydrogen. So if I have to retain sodium back, I have to push something out. What do I push out? Potassium and hydrogen. That's simple. So where is hydrogen going? Into the urine. So I have alkalosis, and in addition to that, I'm passing more acid into the urine, making me more alkalotic. That is the acid, the paradox. The paradox is I am alkalotic. I have to retain hydrogen. What am I doing? What I'm doing? I'm pushing more of acid out. I'm becoming more alkalotic. Isn't that paradoxical? But then that paradoxical is easily explainable on the fact that I have to retain sodium. That's why. So now you know the reason of paradoxical aciduria. We don't read this up. Okay. And then the extracellular alkalosis keeps mounting, leading towards shift of oxygen to the left, tetany, and mental confusion. And why it keeps on mounting? Because more and more acid is going into the urine. Okay. So how do I manage this? Number 1, fluid replacement by what? Sodium containing fluids. And one of the better fluids is the isolate G, which has got all the proportions of sodium, potassium, and chloride. Yesterday I told you the electrolyte contents of the gastric juice should be memorized. So immediately you know I'm losing 60 something, I'm losing 10 plus this and chloride. So I have to retain all these. Or if not, then I have to push this in my body with transfusion. So I like to select transfusion fluid which have got the required amount of sodium, required amount of hydrogen, required amount of chloride, required amount of potassium. Is that clear? So sodium chloride administration may not be enough. I may even have to give hydrogen chloride to this patient as 0.2 normal or 0.1 normal HCl. Right? So that may be required in severely alkalotic patients. Severely alkalotic. So this can be done with the help of monitoring the chloride ion and hydrogen ion always. And chloride deficient, remember, the sodium deficient, remember 50% calculation of the body weight, here 20% of the body weight, right? So this you can go and look up. This is just for your help. That's how you calculate the chloride deficient, and that's how you calculate the sodium deficient, right? In addition, what do? You have to clean the dirty stomach. The whole thing is dirty, 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 and dirty. Why? Because putrefacted food lying there, 2 days old, 3 days old, not being shoved out. So it becomes very, let me tell you, very difficult to empty the stomach. Very difficult. You have to use a very wide bore rice tube. So nasogastric tube has to be very, very wide bore. So aspirate everything out. Wash, aspirate. Push in clean saline, aspirate. Push in more, aspirate. So it has to be continual washing. Push, aspirate. Push, aspirate. Right. Along with that, what else? So this requires almost 4 to 5 days for cleaning, and that also 2 to 3 times per day. And every time saline has to push. You can do it with water. Can you do it? You can't. You can't. You'll create more of hypokalemia. What are you pushing out? Sodium. And what are you pushing in? Plain water. Does it have sodium? Hardly any. So never do it with water. Remember that. Never with water, physiological saline. Number 2, high protein diet. Why? Because I'm not being assimilating in the body. Why? Because the stomach is not digesting anything. If nothing was going forward, only 10 to 20% protein digestion. Remember yesterday I told you how much protein digestion in the stomach? 10 to 20%. What about the rest 80%? Not being digested. No food is reaching the distal part of the bowel. So I'm severely hypervolemic. RDN albumin in my body. So high protein diet, electrolytes and vitamin deficiency should be corrected, and then I can go ahead and do a surgical procedure. What is most of our surgical procedure is I have to take care of the obstruction. At the same time, I have to take care of one more thing, which most of the people don't understand, and that is the stomach may be so dilated, hugely dilated, that the ability to peristaltic activity has gone down so much that there is some element of gastroparesis in that. Now, if you find the stomach hugely dilated and some amount of gastroparesis, then you have to shorten the stomach. Just doing a drainage procedure may not be enough. So just doing a drainage procedure is not enough in these circumstances. You have to do what? You have to shorten the stomach. So if the stomach is hugely dilated, gastroparesis in these instances, what you have to do is you have to do gastrectomy. And if you find that this patient has got a stomach which can revert back to normal peristaltic activity, just do plain and simple drainage procedure, namely truncal vagotomy gastrogenostomy. Gastrogenostomy, the operation of choice. Why? Because these patients are already low in albumin, low electrolytes, low vitamin, low in general body ability. So a major procedure should be avoided. Gastrogenostomy is the minimum that you can do. So you do either truncal vagotomy pyloroplasty or truncal vagotomy gastrogenostomy. Yes. But as I said earlier, massively dilated stomachs, loss of tone of the gastric wall, chance of gastroparesis, a partial gastrectomy becomes the procedure of choice. Is that clear? That is HSV have some role? Yes, it may have some role. We do HSV with Bougie dilatation of the stricture because there is a stricture we're talking about. But often the stricture is so narrow, so distorted that you can't do any HSV. There you do what we said was pylororhynchus, right? Jablois. So do HSV along with jablois. Patient re-stenosis rate is fine. Is that clear? Now, perforated, that I think is the last, perforated peptic ulcer, the last one. Epidemiologically, now more in elderly versus early middle age. Initially, I told you duodenal ulcers were found in which age group? Middle age, right? Middle age. Most commonly 30 to 40, 50 years age. Now it is more than 60. And that is because of the changing scenario epidemiology. Males more commonly, NSAID, the most common cause present day, lead to pre-pyloric perforation or duodenal perforation is usually the ulcer, right? Increasing frequency, gastric ulcer perforations, usually the incisura and anti-abdominal wall, more common in the pre-pyloric ulcer. Just not to be, right? Now, clinical stage, classically, we had those 3 stages. The first was the chemical peritonitis, when described was a board-like rigidity, So sudden excruciating gastric pain, tachycardia, tachypnea, very, very characteristic. The patient is suddenly short of breath. Has to tachypnea or frank dyspnea, because severe pain in the epigastric, everything is like board rigidity. The whole of the peritoneum is absolutely board-like. Even putting a hand to the abdomen is very, very troublesome or very, very painful for the patient, and varying degrees of shock, depending upon the amount or the largeness of the perforation, amount of loss into the bowel, into the peritoneal cavity. So what is irritating? Acid. So it's a chemical peritonitis. So first is the stage of chemical peritonitis. The second is the stage. Now, as soon as the peritoneum has that amount of acid irritating it, immediately there's an outpouring of fluid from the vessels. Outpouring of fluid transferring itself from the intravascular compartment into this third space. We all know peritoneal cavity is what? Third space, right? I'm not going to go back to the fluid-flood imbalance. We all know that the peritoneal space is a pathological stage known as the third space. So fluid has come from the vascular compartment to the peritoneal compartment. So that is the dilution. Now it's getting diluted. It's getting diluted so that acid irritation of the parietal peritoneum is no longer there. So what happens? There is temporary respite. The patient actually feels well. He says, look, after 2-3 hours or 4 hours, he says, my pain has disappeared. Absolutely all right. And you try palpating the abdomen, the rigidity has disappeared. And why does that occur? That's basically because of the dilution of the acid lying inside the peritoneal cavity. So symptoms and signs are basically regressing. The patient actually feels well. But 2 to 3 hours later down the line, now what is happening? The bacteria which were there inside the stomach, I told you it's always bacteria, even bacteria. They basically have been depressed because of the acid. Now they gain access to the peritoneal cavity, start multiplying, and now the patient starts having the stage of infective bacterial infection. And everything comes back. Everything comes back. The tachypnea comes back, the tachycardia comes back, the pain comes back, the rigidity comes back, and now it comes back not to go away. It doesn't go away now. It doesn't go away unless the patient is properly treated. So initially it was spontaneously went away. Why? Because of dilution. So stage of chemical peritonitis, stage of dilution, and stage of bacterial peritonitis. 3 stages to a typical perforation of the duodenal ulcer or a gastric ulcer. Right? Now what has leaked takes a specific route, and that is from the epigastrium, the supracolic, and from the supracolic, the paracolic, from the paracolic into the pelvis, and from the pelvis collects and starts ascending up into the infracolic compartment. So never forget this. Gastric ulcer leaking and duodenal ulcer leaking leaks into the supracolic compartment, central compartment, leaks or takes the route of the paracolic, goes into the pelvis. From the pelvis, the collection starts ascending up, fills and ascending up, and because it is filling, the air is also there, ascends up, and then it occupies the infracolic compartment. Is that clear? Supracolic, paracolic, pelvic, and then infracolic compartment. Now, what is important is that these classical signs are now being found less and less common. So alternatively, you don't find those classical signs. Why don't they appear? Number one, elderly patient. Their abdomen, their wall is so lax that board-like rigidity never appears. Right? So moderate, lax abdominal wall, so the signs are moderated. So the signs are much less. You looking for a board-like rigidity, it's not there. And you say because the board-like rigidity is not there, this cannot be duodenal perforation. Wrong. It's wrong. Elderly patient, the muscle are so lax, they will never find that kind of rigidity. Or a very small perforation, let's say 1 millimeter perforation, immediately sealed up by the omentum, with omentum. So the patient had very severe pain and disappeared. Now you think that probably this patient is dilution, but he never comes to chemical peritonitis. So because of very small perforation, leak into the lesser sac, there's a posterior wall perforation. The signs, typical signs never appear. So a patient who's very old or a patient with a very small perforation or a leak into the lesser sac, the classical signs will not be appearing. Or a retroperitoneal leak. The duodenum, the posterior leak has occurred. It's not burrowed to the gastroduodenal, but it's a leak from the retroperitoneum. Again, the signs don't appear except for the fact that this patient who had epigastric pain now has severe back pain. Severe back pain, but no peritoneal signs. Right? And there you have differentiated from other causes of back pain or severe back pain, chief among them being acute pancreatitis. Right? So differentiate from other causes. Then neglected causes. The patient had this, and say we had a small perforation, there was a leak in the supracolic compartment, the body sealed everything up. The patient didn't come to the hospital for any kind of advice. But 4 days, 5 days, 6 days, week later, now the patient has signs of persistent fever. He's got persistent pain. Now what has happened? Probably a neglected abscess collection, a subphrenic abscess of presentation. Or that leak, part of it has gone into the infracolic compartment, and the adhesions now lead to adhesive intestinal obstruction. And you take a history, patient tells you, yes, I had that severe pain about 7 days back, but then that disappeared in 1 to 2 hours, and I was very happy. So then you start thinking back, why didn't it occur? So that could be another presentation of a neglected duodenal ulcer. So remember, these are all presentation of duodenal ulcer, never forget. So obstruction, a delayed adhesive intestinal obstruction, subphrenic abscess could also be a presentation of a neglected duodenal ulcer. So how do you diagnose? Number one, plain skygram, AP, gas under the diaphragm. In more than 50% patients you find this, rest 50. So don't look for gas in the diaphragm in 100%. That doesn't happen. Then you can do a urgent ultrasound or CCT You can find the dye spillage in a contrast CT. You can see fluid in the abdomen on ultrasound, more diagnostic than a plain sky, especially in those where you don't find gas under the diaphragm. Then you can have a high serum amylase. But then if you high serum amylase, always do a serum lipase. Because high serum amylase, not the prerogative of only acute pancreatitis. No, it can be found in a number of other conditions, acute bowel conditions, even acute cell obstruction. You can have a high serum amylase. But serum lipase is found only in a acute. So if you find a high serum amylase and you find a back pain patient, it could be either a perforated or a penetrating dural ulcer, or it could be acute pancreatitis. So do a lipase. It helps you deciding which one it is, right? So raised serum amylase always combine with serum lipase. How do you treat these patients? Resuscitate is very important. Systemic antibiotic, even more important, and treat as palliative. So that means as soon as a patient comes and you suspect this patient to be having weak perforated ulcer, perforated dural ulcer, always give this patient high-end systemic antibiotics to start with until the calcium reports are available, and resuscitate this patient in terms of hemodynamic stability. And also start treatment of asparagus. Now, that conservative therapy may help a group of patients, a very small, those already patients who have got small perforation. You may be able to tide them over with a conservative. Unlike, unlike the assumption by a number of clinicians, especially physicians, who believe that every patient doing perforation can be treated conservatively. No, sir, no, absolutely no. That belief is absolutely wrong. They may not believe it. Even textbooks say that. Textbook medicine, textbook pediatrics, they say that most of these patients can be treated conservatively. Cannot. So most of these patients have to have surgical intervention. A very few patients who have got very early leaks, very early management of leaks, they can be treated conservatively. But one thing should be there in your mind: even those conservatively treated, conservative treatment, they can always come back to you with symphonic abscesses, and it is an obstruction way down the line. Let's say about 1 week, 2 weeks, even 3 weeks. So don't give it the impression that conservative therapy will be the end of the story for that patient. No, the patient will still come back to you with residual problem, right? Surgery has to be the mainstay, especially what if the patient has got medical comorbidities, diabetes, let's say, he's hypertensive, then early surgery is always good. Don't wait for conservative. 24 hours later, the patient still has the symptom, go ahead and do surgery. Patient is shocked, yes. More than 65 years, yes. Early indications of early surgery. Don't wait. Now, what can you do? You can do lab or open. Either lab or open. Both. Even lab is now an accepted form of therapy in these patients. Okay. So one is simple closure, easiest to do. The second is a patch repair. The best patch is the Graham's repair, and we all know we take and attach a momentum there. See the patch repair, the perforation, you pass stitches like that, and you drag the momentum there and you stick the momentum. This is the Graham's patch. Okay, this is the most commonly done and the best repair today. So that's the patch repair. But when you're doing a patch repair, be careful about one thing. These sutures should not be tight. They should just be tight enough, not too tight. Why? Because remember, the edges of the perforation are very fragile. And the moment you tight them excessively, everything comes samaki in hand. It breaks. Right? So the sutures don't hold, the edges don't hold, and everything that's it. So it should just be tight enough for the sutures to hold back, and number two, tight enough that the omentum does not undergo vascular necrosis. If you apply them too tight over the omentum, the vascular supply goes, so it becomes a necrotic great omentum. So that should happen. You don't have enough of great omentum, mobilize it over the transverse colon. Separate from the transverse colon. Still not enough. The other things we can use as patch. Number one, you can use a gallbladder for a patch. You can use a ligamentum teres for a patch. You can use parietal peritoneum segment for a patch. You take it down, parietal peritoneum, and stitch it to that particular area. Don't do a pexy. Don't do a pexy. But a long segment of the peritoneum can be dragged down and can be used as a patch. The second or the third method is a plug repair. And what's the plug repair? Instead of the omentum just brought over the opening, if it's a large perforation, friable edges, you can push the omentum back. And you can, how do you push it back? Inside the stomach, you can drag a Rice tube out through the opening, attach the omentum to the Rice tube, and then drag the Rice tube back. So it takes the omentum along with it, and now the omentum fixed snugly around the perforated area of the stomach. That's required in those patients where there's a very large perforation. Let's say 1 centimeter large perforation. or more than 0.5 millimeter. A large perforation which you believe that any kind of patch repair is going to break, right? Any suture is not going to hold. So just push in a plug, and with the plug you just attach loose stitches around the margin, and that plug is held in place with the rash tube. Have to be careful on one thing, very, very careful, and that is that the momentum should be attached to the nasogastric tube with catgut sutures. Remember this, catgut, nothing else. Why? Because you don't want the sutures to be there for a long period of time. Suppose you attach proline to it, what's going to happen? The moment you drag the rash tube out, you're going to drag everything inside, and the patient has much more severe problem than what the patient has created that. So remember, the momentum attachment to the rash tube was only with catgut, in as so much that it is going to pull it back and going to remain there for 3-5 days. 3-5 days the catgut dissolutes and the rash tube can be easily brought out without harming the momentum there, right? So that is the third method. The fourth method, of course, is that along with the closure, you take a preventive or make a preventive anterior gastrojejunostomy so that the load on the perforation becomes less. So that is again indicated in large perforations, neglected perforations, or friable edge perforations. So more than 0.5, neglected perforations and friable edges, you can go ahead and do this kind of a surgery, right? Gastric ulcers, always better to do an excisional biopsy, remember that. Excisional biopsy and repair, best. Large ulcers are also there, then you can also do an anterior gastrojejunostomy in these patients if you feel that that particular area is not pulled down. Procedure of choice, however, is if it is a GI unit, optimal condition GI unit, you feel that the perforation is within limits, you can go and do a HSV operation along with the perforation. Along with the repair of perforation, patient's condition good, do an HSV, they do it in a GI unit, they do it along with the anterior gastrojejunostomy, you can do HSV. Or you can do truncal vagotomy with anterior gastrojejunostomy. As it is, you're doing anterior gastrojejunostomy to drainage, just go ahead and do a truncal vagotomy along. But then these are indicated only those patients who can hold up, they are hemodynamically stable, and there you can hope to go in. But these books have, these questions have been mentioned. So if at all you ask, you can mention, you can say that other condition being optimal, the unit being optimal, the surgeon being good, the conditions optimal, the anesthetic is optimal, you can go and do it a HSV, or you can combine truncal vagotomy with anterior gastrojejunostomy or a pyloroplasty. Is a dangerous proposition because that is the area of perforation. So I would never recommend a pyloroplasty, although it's been written, but I think better would be truncal vagotomy along with the anterior gastrojejunostomy, a better HSV, or if conditions demand, you can do distal gastrectomy, which has got the maximum operative mortality. So I would not recommend it. And post-operative PPI is a must in all these cases, right? This is what the Graham study we showed. And thank you. I think we have taken almost 2 hours today. Tomorrow we are meeting with gastric neoplasia, and I think it should be the last part. The rest of the things I think are very small, minor parts of stomach, apart from neoplasia. That I think you read for yourself. Let me decide that tomorrow. But this gastric neoplasia, we meet next tomorrow again at 2 p.m. and that will be the last major part of the stuff. So any questions up to now, you can switch off your phones and can ask me. Or later, if you want to ask me, you can send me a WhatsApp message. So any questions? I think also tired with the discussion, with the lecture, sorry, not discussion. Okay, and thank you. Thank you for your time.
Thanks.
Thank you.